of a treatment that they might attach significance to, and then that risk eventuates, then you're going to be compensating them financially for whatever they've lost as a result of that. So, let me give you an example. Imagine there's a 1 in 15,000 risk of minor sensory loss in your pinky finger as a result of a surgery that will prevent a patient from losing their ability to walk. Now, most patients wouldn't attach much significance to that risk. 1 in 15,000 risk of a small bit of sensory loss in the pinky finger in exchange for the ability to continue walking. But imagine that you have a patient who's considering this surgery who's an international concert pianist. They would attach significance to that, and they probably would risk never walking again to not lose any sensation in their fingers. Civil law. That's probably one of the big areas, and one of the things that I think scares people a bit. Another layer of complexity. If you're the doctor doing that treatment in a public hospital, then they'll probably sue the hospital. But you're in a private hospital, then they'll probably sue you. So we have a bit of a complexity in relation to organisations that you might work for as well. But don't let those sorts of things worry you, because that's what insurance is for, right? You're insured in your practice, and your insurer will fund your legal representation. Unless, of course, your insurer thinks that you should settle and you think that you should defend it. Anyway, so I talked tiny bit about crime. Criminal law, one area. Civil law, another area. Then yet another area, I told you it was complex, regulatory law. And there's a lot of things that fall into this area. So many of you will have come in contact with, no doubt, the NH&MRC guidelines for research. And so the NH&MRC guidelines determines what projects get approved and what don't. And those guidelines, in many circumstances, have the status of law. Other areas of regulatory law include privacy law, which impacts how you collect information and how you retain and store and use that information. And again, if you're doing that in a public hospital, the rules are different to if you're doing that in a private hospital. More complexity. Also falling into that area of regulatory law are complaints and notifications. So notifications are made to AHPRA about some healthcare professionals, doctors, nurses, paramedics, for example, and yet other complaints about health entities and other allied healthcare workers. Some other allied healthcare workers go to the Health Complaints Commissioner. So two completely different processes there. There are other complaint mechanisms too that are unique to health. Over-servicing complaints go to Medicare. Unexpected deaths get reported to the coroner. So, as I said, there's lots of intersections between healthcare, the practice of medicine, and the law, and quite often they raise really interesting ethical issues. And these are the sorts of questions that I've found interesting across my career. So I'm going to tell you a little bit about what I've done so that I'm one face of law at Monash that you might feel comfortable approaching. And to let you know that I'm part of a larger health law group at Monash University who have an interest in a variety of different intersections of the law and health. So I started my interest in law and health when I was an undergraduate student, and I joined a hospital ethics committee. Now, at first I joined as the lay member, and we're approving or not approving research being done within the hospital. And then as I progressed, then I joined different hospital ethics committees as the legal member. And that was a really good way to see the operation of the NH&MRC guidelines on research from the other side, to those of you who are involved in human or animal research. I then, as an undergraduate student, I said that I'd done a Master's of Bioethics, and I also did an honours thesis in my law degree. I'm going to tell you a little bit about that because this is the area that I'm most interested in, the regulation of in vitro fertilisation. So I wrote a thesis on IVF regulation, and my topic was about the regulation of fetal egg donation. So let me explain this. Back in 1994, there was a proposal that the undeveloped oocytes eggs from aborted female fetuses could be harvested, matured, and then donated to women who were looking for eggs for their IVF treatment. So I'll just see if you've quite understood how that works. The working title for my thesis was "My Mum Was an Aborted Fetus." Now, I've always loved these questions, these ethical questions. And so I thoroughly enjoyed my year of working on that thesis. And these are the sort of questions that I was asking myself. If a woman has an unwanted pregnancy and terminates that pregnancy, who's responsible for what happens to the terminated fetus, the fetal material? Is there a sense in which that's her child and she's the parent and she has parental rights and responsibilities over that aborted fetus in order to determine whether the eggs can be extracted and donated? Or is that medical waste, in which case it's the hospital's responsibility? And I suppose it only really matters if someone wants it, and in this case, scientists wanted it. And then how much do they want it? What happens if money gets involved? Could a woman start selling her aborted fetuses in order to extract those eggs? Could the hospital make a profit from selling those eggs? And if so, would they have to account to the woman? Anyway, this is what I spent time answering. Now, you probably at the end of that want to know, well, what's the answer? What's the answer? What's the short answer, Nikki? And can I tell you something very important about lawyers? Yeah, we don't give short answers. Probably when you're involved in the world of technology and innovation, you probably think that lawyers have a tendency to say no. Well, we don't always say no, but we often say it depends. In order to give useful legal advice, we need lots of really detailed information. And I'll talk to you a little bit more about how you get good advice and information out of lawyers. But I'll start with telling you that we don't buy and sell eggs in Australia, which is pretty interesting when they do it in the rest of the world, and we're in a global pandemic, can I tell you? All right, so then when I finished my studies, I started working as a solicitor and in a big law firm that practiced in health law. I was very excited about that because I thought I'd have lots of fascinating questions about end-of-life decision-making. And in fact, I found out that a lot of the questions were about leasing cars for doctors and hiring MRI machines, which was not as exciting as I thought it might be. But I did do a lot of work in relation to consent, patients giving consent for procedures. And I find that a really interesting area of law, and an area that's ripe for automating because it can be a complex process, and which can be really fraught with difficulty. And the law is enormously complex around it, and it's fundamental, isn't it? A patient consenting to the treatment that they get. So, when you're obtaining consent from patients, you don't want to be getting that consent when they're in pain. So if someone comes in with a broken arm, you want to relieve the pain of the broken arm first and then discuss the risks of surgery for setting it. On the other hand, you don't generally want to wait to get consent from a patient who's having surgery until after they've got their preoperative medications on board. You don't want to be getting consent generally from people with drugs on board, except if they're in pain and you need the drugs to reduce it. Yeah, see, it always depends. Talking about consent has other complexities too. Obtaining consent on behalf of children, you generally ask their parents, and their parents make those decisions in the child's best interest. But at the other end of life, when we have, let's say, older people, perhaps who are incompetent adults, maybe they have dementia, and someone else has to make a decision for them, then that someone else, the substituted decision maker, doesn't make the decision in the best interest of the older person. They have to make the decision that the older person would have made, because it's a substituted decision, even if that's not what might be considered in their best interest. So there's some real complexities there, but what you see is that autonomy really underlies the law in Australia. That's really, really is key, and it's the same. I think any ethicist would say the same thing too, that autonomy is key in relation to the law as it intersects with healthcare. When I was working as a solicitor, I was also advising medical practitioners and allied healthcare practitioners in relation to complaints, notifications that were made about their professional conduct. So doctors who refused to give contraceptive advice to young women because of their religious views, paediatric nurses who were watching kiddie porn in their lunch break on the children's ward, dentists who were huffing, nurses stealing pain relief for their drug-addicted family members. And you might think that I didn't love doing that, but you'd be wrong, because I did. I adored being involved in that kind of work. Maybe not you probably think because it's just salacious and I sound like someone who likes those sorts of things, but it wasn't that. What it really was is that it's not like the criminal law. The criminal law is all about punishing people for their bad behaviour. And what I don't like about being involved in criminal law is pretty much no one ever comes out of jail a more productive member of society than when they went in. But this regulatory law I really enjoyed because it was a form of what we called restorative justice, because the aim of these professional disciplinary proceedings was not to punish the person who did the wrong thing in their workplace, but to determine what level of insight they had about their wrongdoing and to work out what can we do to find out what this, why this valuable member of a caring profession has strayed, and what can we do to restore them back to ethical practice. And that's why I liked it, because it was forward facing. So then, to tell you just a little bit more, really just using anecdotes to give you a broad overview of different areas of the law that might intersect with the things you're interested in. I then joined the board of VARTA, that's the Victorian Artificial Reproductive Treatment Authority, which, in broad terms regulates IVF in Victoria. Finally, something like 20 years after I wrote that thesis, which, by the way, they still don't use donated eggs from aborted fetuses. Well, I probably should tell you that, in fact, I don't think they had this great system at the time. That's what they really wanted to do. But in order to try to get approval for that, they came up with something more outrageous in the hope that if they said, can we do X, everyone would go, no, and then they could come back with, what about Y? So what they said they wanted to do was to use eggs from apes. That didn't go anywhere. Anyway, back to VARTA. So really interesting in the regulation of IVF in the last couple of years is the time to tell legislation was introduced. So it used to be the case that sperm donors donated anonymously. Now, you know who the biggest cohort of sperm donors is, do you? It's med students. It was med students. So yes, all of you professors. So the sperm donors used to donate anonymously. And then over time we learned that the donor-conceived people who came into existence as a result of the donation of sperm were harmed by the fact that they didn't know who their donor was. They suffered from a sense of abandonment, a bit like adopted children can, and they might suffer from genealogical bewilderment, not knowing their background. And so the government in Victoria did something that lawmakers normally never do. They introduced retrospective legislation, backward-looking legislation. Now, there's a thing in the law called the rule of law, and amongst other things it says the law applies equally to everyone. It's one of the things it says, it's key. It also is forward-facing, because the law is about trying to regulate people's conduct in society for the betterment of society. So we have criminal laws. It's better if people don't bonk you on the head every time you leave the house or try to steal your money. You don't regulate people's behaviour if you change the law looking backwards, only if you change the law looking forwards. So it was quite significant that this retrospective legislation came into force, which said, all of you sperm donors who donated in the past anonymously, the donor-conceived offspring from your sperm can now apply and be given your identifying information. Now, if you didn't hear the controversy, you won't be surprised to know that this didn't go down all that well amongst many of those anonymous sperm donors. And so one of the things that VARTA's done is overseen the impact of that, which has been really very interesting, I'm sure you can imagine. All right, so what's the message that I want to share is that the law intersects with medicine at many points and can be very complex. The law is complex, and there's a lot of different sources of law and areas of law, and they largely work relatively well together. But if you wanted to compare the law to the anatomy of a human body, pretty sure the human body functions better as a whole than the law does. But there's just as many systems involved, that's for sure. So if you have a legal project, if you've got an idea, if you've got a concern, what I'd like to say to you is see a lawyer early on, but it'll sound like I'm spruiking for work. And that's not really what I'm trying to say. And in this university environment, what I'd say is see a law student, see a law lecturer, see a law clinic. So I'm not suggesting you spend all your hard-earned cash on seeing a lawyer in a commercial context, but make contact. So, for example, we have law clinics, and there's the Monash Law Clinics operate both at Clayton and in the city, and one of the city clinics is a clinic for commercial startups, and that would be a place you could go to for some advice. One of the work integrated learning projects, a clinic that I would be very interested in running, is one between law students and med students in relation to helping older people, actually all people, who enter into hospital to write advanced care directives. Because we know that less than 20% of our Victorian population have these advanced care directives, and yet they determine who decides what happens to us if we become incapable of making our own treatment decisions. All right, now, if you do go to see a law student, you're not to be disappointed with them if they utter the terrible lines, "Oh, I'm sorry, I haven't done that subject yet," which is very frustrating, but they say it a lot. So just as if you start studying medicine, every time someone feels sick, your name will be called out, "Oh, ask so-and-so, she's a med student." The same thing happens, of course, to law students. Most of the subjects that are important in the intersection of medicine and healthcare and law are not compulsory units. They're optional units. So forensic medicine, health law are optional units. Intellectual property is an optional unit. Privacy law, I don't think privacy law is even an entire optional unit. I think it's part of an optional unit. So not every law student is going to be all that helpful to you. So I know in medicine they give you first aid lessons in the first couple of weeks, which gives you a bit of a confidence boost. The useful thing that a law student who hasn't studied all the subjects yet can do is at least listen to your issues and determine perhaps the right person for you to talk to. In the same way that if at the MCG someone has a heart attack and your name gets called because you're the med student, the useful thing you can do, of course, is to call 000. I say that to you as a lawyer. All right. There's one more thing that I'd like to share with you, and do feel free to jump in with questions. I hope I haven't been ignoring the chat. Maybe I need to open it. There's one thing that I would like to say to you is that the practice of law is changing. And so I'd like to give you a heads up as to how you could use that in the innovations that you might be interested in running. And I might just turn my video off for a minute because I'm about to freeze, and hopefully this will preserve the bandwidth. So the good news is that law services are starting to become unbundled, or at least some providers of law services are starting to unbundle their services. So instead of just the top end of town offering very expensive full service suite of legal advice, some of the new recent graduates are offering unbundled services. So just answering the question that you actually want asked. Clinics for startups are running at most of the law schools, and these hackathons that I know MYMI organises are becoming a thing, and entrepreneurial law is becoming a thing, and so you should have more access to law students who have an interest in assisting. Now, I think my unstable internet is back to normal there. I'm very happy to answer any questions that you might have, and otherwise would direct you to the MYMI website to look at the people in the law faculty who'd be happy for you to reach out to them if ever we can assist with any advice. Thanks, Fawn. Will I throw back to you?
Yep, we did have a few questions, so I'll just read them out for you to
answer.
Thank you. So the first one's on Leia about AI and machine learning. Considering that data has seen extreme interest over the years and is very important to make any machine learning improvements in the industry, will there be any exclusive regulatory government agency to monitor and have scrutiny over how these data is used?
Well, will there be? Quite possibly. Is there now? No. And it's a great example of the law really struggling to play catch up. I mentioned the rule of law earlier. Law has to apply to everyone and everything, and it can be really difficult to hive off one particular thing to regulate and then also imagine the impact of that regulation on everything else. I certainly would encourage you, if you're on LinkedIn, for example, or other sites like that, to take a look at search for hashtags like AI, machine learning, and see what lawyers you see up there who post regularly on that. I won't mention them all by name now, but if anyone's particularly interested, get in touch. But you'll find that it's an area that there are a couple of Melbourne lawyers who are very vocal about on LinkedIn, and that could be a useful source of information for you.
Awesome, thank you. And we had another one from Rachel, which was, in terms of parenting making decisions for their children, do you think that parents should have the right to refuse getting their children vaccinated, assuming that the child is not immunocompromised?
So really interesting, when parents make decisions, healthcare decisions on behalf of their children, they have to do so in the best interest of the child. And, based on medical advice, the best interest of the child is normally going to be that the child be immunised. Now, the question was, do I think parents should have the right to refuse? Perhaps rather than give you my personal opinion, bugger it, I'm going to give you my personal opinion. I'm into vaccinations. I think they're a good thing. But what I will tell you is that, for example, there is a law that says, and this was introduced largely to deal with the situation where there are particular religious groups, Jehovah's Witnesses are one, don't tolerate, that might not be the right word, anyway, would refuse blood transfusions. And so a Jehovah's Witness parent might refuse a blood transfusion on behalf of their child, and they would say that that was in the child's best interest. And to a non-believer, that might seem hard to see, but if faced with the choice of a blood transfusion and living another 70 years on earth, but then resting in eternal damnation, I can see why that might not seem to be in the interest from the perspective of a believer. And so we introduced legislation into the Human Tissue Act that said that if a child is likely to die or suffer serious health consequences as a result of not having a blood transfusion, that transfusion can be given against the parent's wishes and even against the child's wishes. And it's to deal with the situation where a young adult in a religious faith may struggle to know whether that faith is for them for the rest of their life. And therefore, they're not really in a position to make an informed decision. And so the legislation says, two doctors say this child is likely to die or be seriously injured. They can be given a transfusion to save their life against their parents' wishes. So I give you that example. Compare it perhaps to the not immediate health risk but long-term health risk of vaccination, and that might help you come up with your own answer. What I can tell you is that the no jab, no play policy has received some significant attention in relation to human rights, and one of the Professor Paula Gerber at Monash University, I know, has written about that in The Conversation in the last year or so. So you could Google that if you were interested in looking at it from a human rights perspective, a rights of the child perspective. Thanks, Vaughn.
Thank you so much for your talk. That was excellent. And Nikki will stick around for a bit after the session is over and maybe answer some further questions. So thank you again. So we'll just move on now to the next one. Marjan is a master's student of mechanical engineering and she will be presenting on a study that aims to numerically investigate the effects of insertion lengths of cannulas. So take it away.
Okay, thank you. I'm going to share my slides. I have to ask before. Can you hear me?
Yep.
Okay, that's good. I was just. You can see the slide as well, right?
No.
Okay. What about now?
Yep, we can.
Okay, great. I'm gonna do this. I'm sorry, just a second. Okay. Thanks for having me here today. My name is Marjan, and I'm a research assistant at Create Lab at Monash University. I'm going to talk about a specific design of inflow cannula for ventricular assist devices. To start with, I'm going to give a short introduction, starting with heart failure. Heart failure is a condition that heart can no longer work on its own. So it's one of the most significant burden of the healthcare systems in Australia and worldwide. The American Heart Association estimated that more than 6.2 million people have had the heart failure problem during the years 2013 to 2016, and this number is increasing by 1 million everywhere, and this is only about the United States. So if you consider this increasing number and also the limited number of heart donors, the clinicians have no other choice than looking for other possible solutions. That one of them could be the mechanical circulatory support system, among which the ventricular assist devices are the most clinically used devices to support the heart failure problem. These devices had, through the technological advances in the last decades, had improved in terms of efficiency, but there could be still limitations. The survival rate of these devices is getting to 90% after 1 year of implantation, but these limitations can still like the thrombosis, bleeding, and the other limitation that I'm going to talk about and focus in this presentation could be resolved. One of them is the suture link around the cannula inlet, which you can I can't see my mouse, I'm sorry. Okay, here it is. Okay, one of these limitations is the suture link around the inflow cannula. You can see it in the picture. This ventricular assist device basically extracts the blood from the ventricle and then moves it through a pump and return it to the body with a required head that it needs to be delivered to different organs of the body. But this is done through cannula, which is inserted to the ventricle, and the surgeon during the surgery needs to suture this ring around the inflow cannula. This is a very time-consuming process, and during this time, the patients need to be connected to a cardiopulmonary bypass devices, which itself has shown to have some complications such as organ failure. So the idea of having this sutureless cannula is really appealing because in that case, the time of the surgery would be decreased. Then you could skip using the cardiopulmonary bypass device and all these associated complications. You would reduce the blood loss of the patients and the cost of the treatment and the time that the patients need to be in the hospital. So our research team that I work in has developed a specific design of a sutureless cannula which is inserted to the apex of the ventricle with a core device. When it's completely protruded inside the ventricle, it would be a part of it would be retracted and create a flared area. These faces inside and outside the ventricle would provide a very mild myocardial force compression force that kind of seal the ventricle from any blood leakage. In the next step, this coring device would be detached, and then the pump, which is shown in the last picture, would be connected to the cannula. So far, this looks good, but the other challenges would be this new design of the inflow cannula that you can see in the picture, how it's going to affect the hemodynamics of blood inside the ventricle. So, if you look at the other studies that have been done on the ventricular assist devices and the hemodynamics associated with these devices, there are different regions has been introduced as possible source of thrombosis due to the, worse hemodynamic characteristics. It could be in the outflow graft that is returning the blood through the circulatory system. It could be in the aortic root, in the left atrium appendage for the people who has it, and inside the pump around the impeller. And one of these regions is the cannula, which we are talking about. This cannula has been investigated in different ways. The place that it could be inserted into the ventricles, the angles of insertion, and the insertion depths. For example, how deep you're gonna put the cannula inside the ventricle and how it's gonna affect the hemodynamic characteristics. The shape of the cannula. In this picture, you can see 5 different shapes. The last one is the design that our research group provided, but the other 4 designs are currently used in different commercial VATs. So in a study that was run by one of my colleagues, these 5 designs are compared, and it was shown that the sutureless cannula with the flared region can provide an improved hemodynamic characteristics in terms of residence time. It means that the time that blood will stay in a certain area, and also stagnation areas. But this study is that I worked on was going to investigate different insertion lenses of this specific type of cannula and hemodynamics inside the ventricle. With this aim, we considered 2 different parts for the insertion lens of this cannula, the tip lens and the flared lens. We considered different values for these 2 parts, and in combination of these 2 parts created overall 5 different total insertion lenses. In the next step, we implanted this cannula into a patient-specific left ventricle design, which is dilated and needs the VAD implantation. And then we considered our aortic valve to be closed all the time. We considered the left atrium as a simple cylinder, and to be able to simulate the inflow jet from the left atrium into the left ventricle, we used the parametric design of the VAD from previous studies. In the next steps, we created the mesh structure that we need for this study, and we conducted a mesh independence study to make sure that it has the right accuracy. And then some of the simulation assumptions are mentioned here. We considered that the mitral valve that we show you in the previous slide would be closed during the systole, and during this time it would be replaced with a simple wall structure. And the non-Newtonian behavior of blood was described with Koru model. We applied a variable boundary condition at the atrium inlet, and to compare the different design of the cannula, we looked into developed flow field, wall shear stress, and stagnation volumes. Okay, if you look into the velocity contours in a cross-sectional view of the ventricle, this one is for the cannula, which was previously used in other studies, and it shows the high velocity jet from the mitral valve or left atrium into the ventricle. Then during the cardiac cycle, it creates some recirculation areas around the VAD structure, and these recirculation areas would be later disturbed toward the inflow cannula and go to the pump. Yes. Okay, if you look at the WSS or wall shear stress that is happening on the cannula walls, you see that the maximum values are mostly happening around the cannula tip, which is expected. These maximum values are changing during the cardiac cycles for different models, and if you compare them with the previous results by other studies, it's in good compliance with previous studies. It means that based on previous studies, the shorter cannula length, insertion length, would result in better hemodynamics. This was generally the trend of results, but with some exceptions. Interestingly, the longest cannula insertion length resulted in the minimum WSS or wall shear stress. I should probably mention this, that these wall shear stresses are known to contribute to blood cells destructions, which can contribute to thrombosis and bleeding. So that's why we chose them as one of our benchmarks. So if you look at these maximum values, these are extremely reduced for the longest insertion length, which can be attributed to the high recirculation areas around this cannula. These recirculation areas will dissipate the energy of those flow, and when it disturbs towards the cannula inflow, it will create less WSS on the cannula tip. But if you compare each two cannula with the same flared length, for example, number 2 and number 3, and you see how the tip length is affecting the hemodynamics, you see that M2 and M3, the yellow line and the black line, you see that M3 with a longer insertion length is creating less WSS values and a better distribution of wall shear stress. And also, if you compare the cannulas with the same tip length but different flared lengths, you can see that in compliance with the previous studies, the shorter length is resulting in the better WSS distribution. If we complete our discussion with the stagnation volumes, we can make a better decision on which design is providing a better hemodynamic characteristics. Stagnation volumes are identified in this study by regions that in those regions velocity is less than 10 to minus 3 meter per second, and strain rate is less than 100 per second. So the red areas that you can see in the picture are stagnation areas, which are known again as possible source of thrombosis. If you see the chart, you can compare different design and stagnation volumes that each of them are creating during the cardiac cycle. So again, shorter cannula is attributing to less stagnation volumes, and the longest insertion length, because of those higher recirculation areas around the cannula, is creating more stagnation volumes. In general, if we want to conclude a certain statement, we can say that in line with the literature, shorter overall insertion lengths can result in lower stagnation volumes and wall shear stress, but for this certain design of the cannula, shorter lengths and longer tip lengths improve the hemodynamics. For future works, we would suggest that we modify the design of this sutureless cannula based on the common shapes of the left ventricle. In the end, I would like to acknowledge Dr. Sean Gregory and Dr. Sam Liao for their incredible mentorship and supporting this study, and also the Monash University, Baker Heart and Diabetes Institute, and National Heart Foundation of Australia for their support. Thank you for your time.
Thank you so much, Marjan, for your talk. You do have a question in the comments. I'll just get you to look at the chat and then reply by text.
Yes, sure.
Thank you so much. And now we'll move on to our next talk, who is Calvin, who is a fifth-year undergraduate medicine student. His talk will be on the work of Santiago Beltran, who we just heard talk during Toucan panel. So, Calvin, when...
Perfect, guys. 1 second. I just have to get my PowerPoint up, and then I'll get going. So... is that showing my screen now?
Yes.
Perfect.
Not yet, actually. Sorry.
Okay, so on the way. So I'm Calvin. I'm a final year medical student at Monash, and next year I'll be working at the Alfred as a junior medical officer. I collaborated with Santiago, which we have heard from before, with his project on Toucan Medical. And really what I'm going to be talking about is a bit on the background behind the project and behind hospital-acquired complications and infections. So the first thing that I want to talk about is that a lot can go wrong in hospital. Here's a bit of an overview of what the government considers as a high-priority hospital-acquired complication. We've got things like pressure injuries, we've got things like kidney failure, we've got things like delirium. The one we're going to be focusing on is healthcare-associated infections here. And really the worry that people have with this is that if you have a complication in hospital, that means that you're going to be in hospital longer than you expected before. You're going to have poorer patient outcomes, and you're going to have greater treatment costs. So obviously you've got both the government and the patients being quite concerned about this. So focusing on hospital-acquired infections, there's about, based off this study by Graves et al., and it was published in the Medical Journal of Australia, there were over 175,000 cases per year of hospital-acquired infections annually in Australia. So that's not just from the cannulas, but it's from everything. And this required, almost 1 million additional bed days to treat. So the concept of a bed day is really a day in hospital that you would have to spend. And what we're trying to say here is that there's too many patients were staying much longer than they had to originally because they got an infection from hospital, not something that they've come in with in this case. So even if we were to change that by 1%, if we reduce the rate of hospital-acquired infections by 1%, that would translate to almost 40,000 additional hospital admissions for things that would be, somewhat unavoidable in that case. So I guess as well, I'm sure we've heard all about cannulas all of today, so I'm not going to go into great detail, but this is just a picture of one here. So it's, of course, a needle that puts in a plastic drip. That means that we can give medications, or we can give fluids, or we can take bloods at any point without having to prick the patient again, is the idea. Okay, so what we're focusing on today, and this is a kind of a bit of a spread of how hospital-acquired infections are distributed. So the bloodstream infections are really what we're focusing on with the cannulas. Things like surgical site infections and pneumonias, of course, other big issues. I guess thinking more broadly, Toucan is focused on the bloodstream infection side of things and a very niche part of that. But of course, there are a number of other issues in healthcare where iatrogenic or hospital-acquired infections or complications are a big issue. So, targeting things like surgical site infections and pneumonia would be perhaps targets for other projects in that sort of case. So, again, on peripheral intravenous catheters or cannulas or drips, so lots of different names for them, 80% of hospitalised patients will have an IVC. There's a 0.1% chance of them being infected and them getting a bacteremia. Bacteremia means you've got bacteria in the blood there, and there's some significant complications if you end up with this sort of problem. There's an all-cause mortality of 26.5% here, which is really significant in that case, and a lot of these staph bacteremias have been attributed to these IV cannulas. So there's a bit of a diagram here, which I think is a good one that shows, I guess, the problems with the IV cannula. And there's lots of places where you can get contamination. Let's say you don't clean the skin properly. If you don't clean the skin properly, you could get some contamination from that. You might not clean your hands properly, which might mean that you contaminate the entry port. You might not put the needle or the catheter on a sterile field, or you might accidentally touch it on something that's not sterile. And in any of these ways, you could really introduce the bacteria in. So the main problem, just to reiterate, which I think a couple of the other speakers as well have talked about, is that so many patients will have a cannula, even though there's a low chance of infection, they're still pretty likely to, the scale of it's still going to be pretty high. So I'm going to talk about 3 approaches today. One of them will be Toucan's approach. One of the approaches that the hospitals have been taking, this is a project that the Alfred has undertaken maybe about 7 years ago or so, and they integrated a program up, realising that there was an issue of the cannulas, integrating phlebitis scoring, standardised equipment, and staff education. What phlebitis is essentially like scoring how infected the cannula looks and how infected the drip looks. Here's a picture of it on the side for reference. And they were able to actually lower their staph bacteremia rates by 63% there. So obviously hospitals are concerned about this, and they're trying to fix the problem as much as they can. The second way that I wanted to talk about, and this is actually a study from, I'm actually doing a course from the guy that wrote this study. He's an emergency physician, and he actually talks about ultrasound guided cannulation, so he's quite well versed in the field. And I guess the study that he went for here was going for the fact that, as we mentioned before, a lot of the cannulas are unused, so people get cannulas just in case when they probably wouldn't have needed one. He devised a bit of a protocol for deciding when a cannula will be relevant and when a cannula won't be. He called it APIVC. I don't have what that acronym actually stands for off the top of my head, but really the idea was that you had to have essentially an 80% chance in your mind, like as a clinician, that this patient would actually have their IV cannula being used. So proper ways to use an IV cannula might be to give fluids, IV contrast, IV medication. So if you're sure about that, you put a cannula in. But things that, I guess in the ED, from my experience, things where you give a cannula when it might not be so useful is when you're taking bloods. You might be taking one round of bloods for a patient, in which case you'd probably prefer to do something like a venipuncture. So this picture here is a venipuncture where you prick the vein, you get the blood, and then you take it out. You don't leave anything in there after, which is, of course, a much lower infection risk. It's not really as much of an issue in hospitals like that. And finally, getting on to Toucan Medical's approach, which is the device approach here. So here's a bit of a picture of sort of a standard sort of cannulation setup. So there's obviously a lot of different bits and pieces. And as Mariam was talking about before, there's having all these pieces does make things a bit more confusing, makes it more likely to get infections, and makes it take a bit longer, makes it a bit more difficult. Also through Toucan's approach as an aim to reduce unnecessary packaging, because every one of these things in the picture is packaged in some plastic to make sure it's sterile and all that. And if you had one piece, it would perhaps be a lot more efficient there. And the ultimate aim is, based on the study that we saw before, that we're going to be aiming to reduce the number of bed days due to PIVC associated staff. So that's the end of my presentation, guys. Does anyone have any questions on the work that I've done with Santiago?
I don't think there were any direct questions yet, but hopefully you'll stick around, and if anyone wants to have a chat with you, they can. Yep, perfect. All right, thanks, guys. Thanks so much, Calvin. So I'll just introduce now the final speaker for this session. It is Leah, who is the co-director of the engagement team at MYMI with me. This semester, she ran a 4-week workshop series in collaboration with Deep Neuron, which is another student team in Monash that focuses on AI and machine learning. So I'll just hand it over to Leah now.
Awesome. Thanks for that, Vaughn. Give me one sec. I will just go ahead and share my screen. Let me know if you guys can all see that now. Beautiful. Sorry, please ignore the Chrome tabs. One sec, I'll just get myself set up. All right, perfect, awesome. So thanks, Vaughn, for that great introduction. Yep. My presentation today will be about medicine and interdisciplinary consideration. I've taken 4 weeks worth of workshops that was planned alongside Monash Deep Neuron, and can kind of condense it in this short talk. And it's all going to be about exploring the medical, technical, design, and ethical aspects of developing new technologies using AI as a diagnostics tool. So before we get started, a little bit about me. My name is Leah Martinez. I am a mechanical engineering student, and I'm also doing a double degree in arts with my major in philosophy and bioethics. So in terms of MedTech, my specific interests lie, sort of in the domain in, medical and surgical robots, and also a lot on bioethical issues within the advancements of medical technology. I'm also the engagement director of Monash Young MedTech Innovators. And so I guess with the combination of all of my interests, that's kind of how these workshop series came to be. I wanted a platform to kind of introduce this idea of interdisciplinary work in the field of developing new technologies. And so I reached out to the team at Monash Deep Neuron, and alongside them, and also with the team at MYMI, we created a 4-week workshop outlining a number of different components that you want to consider when developing new technologies. And so these are the 4 components that we went through using AI as a diagnostics tool. So we identified these 4 components to be the most important ones to outline for students. So starting off with obviously the clinical side, then getting onto some technical studies in terms of how AI works, the pros and cons of that. We also had Darren from MYMI come and talk about the design aspects, especially around human-centered design. And the last workshop was all about the ethical implications. So for the purpose of this presentation, and also for the purpose of the workshops, we will be referring to malaria as the illness that we will be diagnosing. So starting off with the clinical considerations. So obviously there is already a pre-existing way on diagnosing any sort of illness, whether it's malaria. So the traditional way that doctors have always diagnosed illnesses is this process of first, taking the patient's history, performing examinations, and then, using all of that information to conduct an investigation, and then coming to a conclusion as to what the diagnosis is. And so, although, there is inherently nothing really wrong in the way illnesses are currently diagnosed, there are some difficulties and some biases that have been identified in the process of diagnosis. Obviously, doctors are human; they aren't immune to making errors, and there are certain errors that have been identified and have been taken into consideration. So things like recency bias, so if a doctor had previously been exposed to a patient with a certain illness, there is more chance of them referring back to that information when another patient, demonstrates a similar set of symptoms. Another thing is expertise bias, that we do know that different clinicians have different expertise in different fields, and that means, having more specific knowledge in an area will make them more inclined to diagnose using those tools. Another thing is patient bias, the relationship between a doctor and a patient, and even any sort of preconceived notions that a doctor has about a patient or a demographic of patients will affect their diagnosis. So another thing is people don't always present the way textbooks say that they should present. And, you need to start with a long list of differentials and narrow down. So obviously we do note that there is the existence of different issues on the current state of diagnosis. And so then we now go into ask the question, how does AI help solve this problem? First, we start off with identifying what actually is. So artificial intelligence, as we all know, is, machines that try and emulate the way that people think. And so deep learning is a subset of AI that essentially imitates the workings of a human brain in processing data and creating patterns for use in decision making. So we also know this as deep neural learning or deep neural network. And so in this diagram, what this outlines is a layer of what we call artificial neurons and artificial neural nets, and how they work is similar to a human brain. Like I said before, they imitate the working of a human brain, and each of these artificial neurons hold a certain weight, and the neural network essentially determines these weights based on a bunch of different training. So the components attributed to deep learning is first involving data sets. So you need a large number of data in order to feed into your model and to train it. And that involves a bunch of different processes like training and validation tests, augmenting different data. The second part is, taking that model that you've trained, and that so taking that model that could involve different architectures, transfer learning. So transfer learning is, you can create new AI models by fine-tuning previously trained neural networks. So that means that you don't have to train neural networks from scratch. And so there's a host of different neural nets available right now from Fast AI, PyTorch, different platforms. And then after that, once you start training these neural nets, different factors such as, how many times should you train this network? What is your success and loss rate, learning rates, things like that are like different things that you would take into consideration in terms of the technical side. And so how essentially that looks when using AI as a diagnostics tool is you are taking an image. So take, for example, this input, which is an image of a blood smear of a parasitized cell, a malaria cell. You'd take this input, put it through a bunch of different transformations, and then you'd put it into the AI model. And then essentially what you would want to end up with is after that, that model processes that image and all the different transformations, it will give you an output. So the way that AI works is that it will give you an output, and also it will tell you how certain it is as to what it has concluded. And then from that information, you can make, is the cell parasitized? Is it not? On a broader sense, you'd say, does the patient have this illness or do they not? And so after we kind of have talk through the technical steps of how do you actually use an AI model to start diagnosing different illnesses. How do you use it as a diagnostics tool, especially in imaging? The next consideration that we now go to is this idea of the design component. So one of the main things that MYMI is really centered around is this idea of human-centered design. One of my biggest considerations when making this workshop was thinking about the demographic and also thinking about the idea that personally for me as an engineering student, things that we work towards is very solution based. It's very, trying to find the solution to a problem without considering who it actually affects, who are the people involved in this. And that is a really important consideration that we need to learn to make, especially working in the field of medical technology, where the end users are patients and clinicians and things like that. And so in the workshop series, our president, Darren, did a fantastic presentation on human-centered design. And so I've pulled some of his good design considerations that I think are really key, that are really important to ask in situations. So when designing for people, designing for healthcare, you need to make certain considerations. The first one is to the users. Who is going to be utilizing this technology? What are the needs of the users, and how can we identify these needs of the users? And considering these needs once they've been identified, is artificial intelligence and deep learning the right solution? I think as engineers, some engineers and any sort of like technical role, sometimes we do get stuck in this world where, we try to think of the most convoluted and the most complex solutions to things, but we do need to sometimes take a step back and ask the question, how should we solve this problem? And can AI solve this in a unique way? We do know that AI is making some really great advances, but we also have to consider whether it is the correct solution for that particular problem. And so we did identify some pros and cons of how human diagnosis sometimes fails. And so with AI, even though we do know that, it has a lot of benefits and has a lot of ways that it could potentially fix all of those issues surrounding human diagnosis, AI itself is a fallible system. It's not perfect. And it does have pros and cons that we do also need to take into consideration and weigh out. So AI is a very sophisticated system. It's really useful for making predictions and recommendations. And these predictions and recommendations are very dynamic and personalized content. So you'll find that, AI is used in everyday life, even with your YouTube recommendations and Netflix recommendations. Those are algorithms based on AI. They're very dynamic and personalized as it learns from your behaviors. AI is also really good at recognizing entire classes, and it's also really good at detection of low occurrences events over time. So looking at data, looking at patterns and trends, and looking if there's any sort of discrepancies in that. But one of the big cons of AI is this idea of lack of transparency, which we'll touch on that in a little bit once we get to the ethical considerations. Some cons also include maintaining predictability, trying to automate high value tasks, like if you were in attendance at Josh's presentation, there are some issues in terms of trying to, trying to get humans to trust these machines, and also this idea of high speed, low cost. And so the final consideration that we wanted to make is ethical considerations of AI. And so why ethics? Ethical dilemmas always arise with the development of new, in this case, AI technologies in medicine and in general. New technologies come out. We have yet to see this sort of thing come out. And so new dilemmas, new issues come up. And it's important that we take these into consideration, especially considering what type of users are going to be utilizing this technology in healthcare. And so the main ethical considerations that we made are these ideas of privacy concerns we do know that AI systems require a large amount of data being fed into it for it to learn, and that data comes from users' medical history, which is sensitive and confidential information. And the more data we require, the more users are at risk of privacy breaches. Another consideration is bias issues. So to quickly touch on that, AI systems are only as good as the information that is trained with, and there could be really catastrophic results if the data that you feed into the system is, incomplete, underrepresented, or even misinterpreted. And so that could cause an issue in terms of potential biases against disadvantaged groups and minorities. And one of the considerations that we have to make is what are potential workarounds that we could consider to prevent the bias issues within the system. Another one is this idea of explainability, and the fact that AI systems, essentially, we can't really know how they work because all of those neural networks are quite hidden, and there's a lack of transparency as to figuring out how exactly it comes to its decisions, and that affects the level of trust and the level of care in terms of patient-clinician relationships. And so that's another thing that we need to take into consideration. And the last one is this idea of inequality concerns. So I'm pressed for time, I won't touch on it for too long, but it's just this idea that with AI systems, especially in healthcare, there'll always be winners and losers, and not everyone will be essentially treated the same when these machines are implemented. So that's another consideration that we need to make. Another thing that comes up with this is different legal issues. So, who is responsible when AI makes a mistake? Things like liability and the things about regulations of this technology are things that we also, prompted people to think about. So just to conclude, this idea that concerns about ethical issues in AI should serve as prompts for ongoing conversations about the basis on which we make these decisions, rather than be thought of to constitute a reason to abjure AI. Even though we have all of these different dilemmas that come up, we should use these as kind of food for thought rather than completely axing AI and thinking that it's not a plausible solution, but instead trying to find different workarounds for that. So before I conclude my presentation, I'd just like to give some acknowledgements to Mitchell and Sean from Monash Deep Neuron for their help in this workshop, to Alicia and Darren from the MYMI team, also to Josh, our other keynote speaker, who gave me a lot of help in the ethics side of this. And yeah, so I will finish up there. Thank you for listening to my presentation. I'll pass that on to Vaughn.
Thanks, Leah. That was awesome. That means that we're finished with this session. So we can take a quick break, maybe?
Yep, sounds good.